Good afternoon. So today I want to talk about using a separate cut down or counter-incision technique for reservoir placement in patients with a hostile abdomen. These are my disclosures. So we're going to be talking about challenges of traditional reservoir placement, why use a cut down, why we use the lateral retroperitoneal space, outcomes, as well as conclusions. So we can all agree that the standard location for reservoir placement for prosthetic surgery is the space of Retzius. And we can place it in that space if we make the following assumptions. Bladder is empty, free of adhesions, there is no aberrant anatomy, no bowel, no vascular structures. So this is a patient, great abdomen, sure, let's place it in the space of Retzius. But what happens when you see this? Can we make those assumptions? Is it safe to place something blindly? Probably not. So these patients we encounter, all of us here, and that's when we have to have a decision as to where to place a reservoir. So, as we all know, placing a reservoir is one of the highest risk parts of prosthetic surgery, especially in patients that have had prior surgery in their pelvis. Shown here is a CT scan with that reservoir directly in the bladder. So, also it's been reported widely, there's been bowel, bladder, major vascular injuries from reservoir placement. So, when do we consider a cut-down incision for reservoir placement? So for people here, I would say that we can all agree that perhaps changing the reservoir location is prudent when you have patients with a prior history of prostatectomy, neobladder, cystectomy, conduits, other types of major intra-abdominal surgery. And sometimes you could argue that even patients with prior inguinal hernia repairs require a different approach. We love the lateral retroperitoneal space, and this is an approximation of where we place our incision. So just medial to the iliac crest. This is a patient with a prior cystectomy. So the incision that's made, 2 centimeters, just medial to the iliac crest. Dissection's carried just down to the aponeurosis of the external oblique. And you're gonna see right here with retractors, that nice sheen of the fascia. And you can see the orientation of the fibers, and we're gonna cut that with electrocautery and cutting current. At this point, we'll place stay sutures on each cut side of the fascia, and these stay sutures are going to be used to close the fascia after the reservoir is placed. Now, with the stay sutures in place, this is now where we split the oblique muscle. So this is critical here. You want to make sure that your curved males are straight down. You don't want to go medial. And at this point, after you've split the oblique muscle, now you're going to be using blunt dissection to create a space in the lateral retroperitoneum. So what you're feeling for is the psoas muscle, your extraperitoneal. So simply we place the reservoir using an AP sucker, and that's it. I mean, this is a very, very simple, reproducible technique. So we've published in 2021 a step-by-step guide on placement of the reservoir using this fashion forever in the reference. So even though this technique is safe, or it's at least very simple to use, what are the outcomes? Well, we absolutely have evidence to show that this is a very safe space. So we looked at our patients that had underwent this technique in our contemporary series, and we found that in 266 patients, we had 1 bowel injury. So biggest caveat, this was a very, very complex patient. Prior hemicolectomy, prior Indiana pouch. The nice thing about using a separate cut-down incision was that instead of contaminating the device, the actual spillage was very far away from the actual primary incision. We fixed the bowel primarily, closed the incision, delayed placement of the reservoir in the contralateral space for a few months. Patient did fine. We then looked, we also used this space for every patient with an artificial sphincter. We looked at 541 patients. No intra-abdominal complications during placement, removal, or exchange. So that's critical. It's very simple done at displace, but also to access this reservoir afterwards. We then further looked at very unique subsets of patients. Patients with urinary diversion, 80 patients. As we discussed previously, 1 bowel injury, patient did fine. How about radiation? No issues with complications during placement or removal. How about patients that require both an AUS and an IPP? Well, there's plenty of space. You've got both sides of the retroperitoneum. So we showed 39 patients in neobladder, so very complex hostile abdomens, and there's no bowel injuries. So in conclusion, counter-incision cut down should be considered. If there's any uncertainty regarding the safety of the space of Retzius, we have over 800 cases in our contemporary experience, doesn't even count what we've done previously for decades before, that show this is a very safe, easy, efficient technique, doesn't increase any surgical time, and no increase in morbidity. As we all discuss here further on, prosthetic children should just be versatile. You should be confident in different ways of placing reservoirs. Thank you.